Thank you very much. Welcome to this congressional briefing organized by the Breast Cancer Early Detection Coalition and Women's Health Advocates. Thank you for joining us for this vitally important issue. My name is Linda Goler Blount, and I'm president of the Black Women's Health Imperative. Today, we're honored to have opening remarks from Congresswoman Rosa DeLauro of Connecticut, who is a champion for many health issues and most importantly, for defeating breast cancer. She is not just the ranking member of the powerful Appropriations Committee and its Health Subcommittee, but also the original author and co-sponsor of the Find It Early Act. She is an ovarian cancer survivor and champion for women's health in Congress. Now let's hear from Congresswoman DeLauro.
Hello, everyone. Congresswoman Rosa DeLauro here, representing Connecticut's 3rd Congressional District. I want to take a moment to express my gratitude for all the hard work and dedication you have put into the Breast Cancer Early Detection Coalition. Your efforts are truly making a difference. I would like to thank my friends Kristen Dahlgren, Dr. Rachel Brem, and all of the wonderful speakers for joining this crucial online briefing on the importance of early breast cancer detection. Early detection of breast cancer is key. 99% of women who receive an early breast cancer diagnosis survive it. However, nearly half of women have dense breasts that require screening beyond a mammogram for accurate early detection, but those tests are not covered by insurance. I worked with my Republican colleague, Congressman Fitzpatrick, to require the Food and Drug Administration to develop a nationwide breast density notification standard. This rule, which finally went live in September, requires providers to inform women with dense breasts of their status and the need for further screening to potentially detect cancer. However, many women who do not receive insurance coverage are still faced with out-of-pocket costs. That is why I have championed the Find It Early Act, which will ensure that these life-saving screenings will be covered with zero out-of-pocket costs regardless of insurance. Last Congress, we garnered more co-sponsors for this bill than ever before. But we have more work to do. We must educate and empower women to advocate for the screening they need. And we need insurance coverage for all supplemental screenings and technologies, such as ultrasound, MRI, and more. Thank you again to the speakers for your advocacy and your continued efforts to elevate this issue. I want to particularly thank the survivors and thrivers who share your stories so courageously to educate Congress and the public on the importance of screening. Without you, we would not have been able to come this far. Thank you from the bottom of my heart. Together, I know we can get this done.
Thank you so much for those energizing remarks, Congresswoman. Now, I'd like to share a little background on the importance of accurate screening guidelines and access, and share what we're doing at the Black Women's Health Imperative. The United States Preventive Services Task Force has recommended that women of average risk begin screening at age 40 and do so every other year. The studies on which they based these screening recommendations were largely conducted outside the US, primarily Sweden and Canada. Black women get breast cancer on average 5 to 7 years younger than white women and are more likely to be diagnosed at a later stage, and as many of us know, have a 42% higher mortality rate from breast cancer as compared to white women. It's important to note that there's no biologic or genetic explanation for the difference in mortality rate. This disparity simply reflects who gets access to high quality and timely care, early detection, and who doesn't. There were no Black women in the studies that the USPSTF used, so the question remains, should Black women screen earlier than white women? To answer that question, BWHI is conducting the first ever study of screening mammography among Black women. We aim to understand what their experiences are from the moment they enter the imaging center to the last day of their treatment if cancer is diagnosed. We hope to inform the USPSTF's screening guidelines and provide data on Black women and mammography to ensure those guidelines reflect their experiences and promote early detection and survival. The study, which is being conducted in Alabama and Georgia, is in its early stages, with about 150 women having been recruited in Alabama so far, and we've already found 3 cancers, 10 times the expected rate. This is just one example of the power of breast cancer early detection, of the Breast Cancer Early Detection Coalition and Women's Health Advocates members who work to bring data and science and the lived experience to policy to improve women's health. So stay tuned, look for updates on our research, and together we can bring early detection to all women. So now I am thrilled to introduce our first speaker for today's congressional briefing, Kristen Dahlgren. She's an award-winning journalist, former NBC News correspondent, and breast cancer survivor, whose on-air reporting about her own diagnosis helped raise national awareness about the signs of breast cancer that often go undetected. Since her diagnosis, she's become a passionate advocate for research and early detection, founding the Cancer Vaccine Coalition to accelerate the development and accessibility of preventative cancer vaccines. Kristen brings the voice of both survivor and storyteller, reminding us what's at stake and what's possible when science and advocacy come together. Kristen?
Thanks so much, Linda. I will say I never expected to be in this space, but thanks to everyone for taking the time today, both for us and for the people you love, because at some point, unfortunately, breast cancer impacts almost every family or social circle in America. And as Linda said, I learned that the hard way. You know, the truth is, I didn't really give breast cancer much thought prior to my diagnosis. I was an NBC correspondent. I was at the height of my career. I had a young child, and I didn't have a strong family history of anyone getting breast cancer before the age of 80. So I thought that I had decades if I had to worry about it at all. Most importantly, though, I had just had a clear mammogram in May of 2019. It showed nothing. My doctor felt nothing. And so I went about my business despite the fact that I must have gotten a letter in the mail that said that I had dense breasts. I'm told that's what New York was required to do and all that New York was required to do at the time. It was not enough. I don't remember reading that letter. Nobody suggested an ultrasound or additional screening to me. My doctor never called me to say that I should or could get better and more effective screening for the type of breast tissue that I and almost half of American women have, dense breast tissue. Let that sink in, because we're not talking about a fringe or a rare situation. This is 40 to 50% of women who have dense breast tissue. So imagine my surprise when just 4 months after that mammogram on my 47th birthday, I noticed a dent in my right breast. It was sheer luck that I had done a story on NBC about the ways that breast cancer could present and that it wasn't always the lump that we might expect. That's the only reason that I pushed for an ultrasound when I myself noticed a change in my body. So it is simply luck that my breast cancer was diagnosed at stage 2 and not much, much further along. By the time I found my breast cancer, though, I had multiple tumors in my right breast, and the cancer had already spread to my lymph nodes, none of which had been seen on a mammogram just 4 months before. That is a failure of our system that doesn't have an appropriate screening standard for and standard of care for coverage for the type of breast tissue that almost half of women have. I went through treatment in 5 days. I'll be 5 years post-treatment. That treatment, though, was devastating, and it's left a lasting impact on my body. If you believe that breast cancer is just about losing your hair and once you're over, you're wrapped in pink and you're called a survivor, I want to share just a few of the impacts that I still deal with every day. I have had 8 surgeries. I need more in an ongoing attempt to just someday feel moderately comfortable in my own skin. I have no feeling in my chest or abdomen. I have painful lymphedema or swelling in my right arm that requires compression garments. My shoulder has limited range. It's difficult to raise over my head. I have fibrosis on my lungs from the radiation that I went through. And I'm in medically induced menopause, which is not just the inconvenience of hot flashes. It puts me at greater risk of heart disease and has made my bones brittle and prone to breaking. I also worry about recurrence every single day and every time I get any type of ache or pain in my body. The worst part, though, is that it hasn't just impacted me. My daughter was just 3 when I was diagnosed. She will never know me without breast cancer side effects. I will never again feel her chest or her against my chest when I hug her. We both deserve better. And that's why I took a radical step. I left my job at NBC and I started the nonprofit Cancer Vaccine Coalition to support incredible groundbreaking research going on right now. Therapeutic cancer vaccines are already in trials, eliminating active disease and saving lives. And yet we aren't accelerating this robust research that could get us there in time to save millions. Imagine a world where we care enough to detect breast cancer early, and then we have cutting edge immune activating therapies to fight it off before it spreads. None of this is science fiction. It's possible, and you all are in a position to help us build this better world for my child and for yours. Please listen to the speakers that are going to follow me today. Cancer is not political. It doesn't care which side of the aisle you sit on. And as I learned, it can upend your life in an instant when you are least expecting it. But we're not powerless to control and even stop it. We can't do any of that, though, if we're not finding it. So that is why this legislation is so important. Thank you so much. Linda.
Thank you so much, Kristen. I know we were all moved by your story, and thank you for how you've turned this diagnosis and your entire experience into this opportunity for the first ever breast cancer vaccine. We've seen the power of the HPV vaccine, and I know thanks to pioneers like you, the next generation, your daughter's generation, will face better cancer treatment options. Thank you so much. Our next speaker also has a powerful story for us today. Kaitlin Christine's story is so compelling as it encompasses the power of early detection, the choices women without insurance coverage are forced to make, and the importance of knowing family history and the value of self-advocacy in our healthcare system. It is also about entrepreneurship and innovation. Kaitlin is a breast cancer survivor and the founder and CEO of Gabbi, a digital health company assessing every woman's risk of breast cancer and expediting her time to the right care via telehealth. She brings a powerful patient perspective and a vision for how innovation and policy can work together to save lives. I'm pleased to welcome Kaitlin to the screen.
Thank you, Linda. And thank you so much for this opportunity to share my story and my mom's stories. These are just 2 stories, but they're 2 of millions, because the truth is, these stories could be anyone. If the Find It Early Act had been in place, my mom would still be here today. My mom did everything right. She got her annual mammograms. She followed the guidelines, but the guidelines failed her. It was Thanksgiving 2012. She had just had a clear mammogram, but there was a lump that was bothering her right by her sternum, causing her pain. She asked if the lump showed up on the mammogram. They told her no. And after some back and forth, they agreed to repeat the mammogram just to be sure. Again, nothing showed up on the mammogram. She had to fight for any other type of screening. She was scared. And when she told me about it while I was home from college for Thanksgiving, I told her, I'll go with you. There are 2 things that I'll never forget about going to the imaging center with her. First, I'll never forget standing with her at the front desk of the imaging center, rifling through her wallet. Insurance wasn't going to cover the ultrasound. She was being forced to choose between paying a bill and knowing if she had cancer, between health and uncertainty, between life and death. I told her, you won't be able to sleep if you don't do this. So we put it on the credit card, telling ourselves we'd figure it out later. The second thing I will never forget was the ultrasound. All I could see on the screen in a dark room was a giant black hole. After years of clean mammograms, my mom, Lisa Clark, was diagnosed with stage 4 triple negative breast cancer in every organ. 8 months later, she was gone. My mom had dense breast tissue, but no one told her. She was high risk, but no one assessed her risk. She was doing everything right, but the right tools were never offered to her. And the only reason I'm standing here today is because my mom died. She shouldn't have had to sacrifice her life for me to have the knowledge that I needed for my own. I found lumps in both of my breasts shortly after she died. I was 23 years old. I also had dense breast tissue. But like my mom, I was told, oh, it can't be breast cancer. You're too young. You're too emotional. Your mother just died. Insurance won't even cover a mammogram for you. But I knew better because of my mom. I knew a mammogram wasn't going to be enough. So I fought. For 9 months, I fought for the right imaging. For 9 months, I fought for the care I knew I needed. Finally, after 9 months of being told no, a breast ultrasound found my cancer. I was diagnosed with breast cancer at 24, just a year after my mom had died. My mom saved my life, but she shouldn't have had to. We shouldn't have to rely on grief to unlock the right care. We shouldn't have to fight this hard for what should already be standard. If the Find It Early Act had been in place, my mom would still be here today. We know how to save lives. We have the science. We have the technology. But what we need now is the will. Early detection should not depend on privilege, persistence, or luck. It should be policy. I'm standing here today because my mom couldn't. So please, don't let another daughter stand here telling the same story. The Find It Early Act is not just policy. It's a lifeline. It's how we change the ending of these stories. So let's make that change together.
Oh, thank you so much for sharing such a powerful story. What I hear is we should just have to be patient. That's all. We shouldn't have to jump through hoops and do these other things. Be so powerful, be so resilient. But thank you. Um, because without your resilience, without your determination, um, you know, so many of us wouldn't have that inspiration to do what we know we need to do, but importantly, to get our providers to do what they need to do. So thank you. Now we turn to our physicians, who will cover key topics, including breast density and its impact on screening accuracy, the rising incidence of breast cancer among younger women, and the costs associated with accessing advanced screening technologies. They will also discuss the toll breast cancer takes on patients and families, as we've heard, the role of AI in enabling early detection, and the policy changes needed to ensure access to life-saving diagnostics for all women. First, we'll hear from Dr. Rachel Brem, professor and vice chair of the Department of Radiology at the George Washington University and co-founder and chief medical officer of the Brem Foundation. She's been at the forefront of advocating for personalized screening approaches and developing novel technologies, especially for younger women and those with dense breast tissue. Along with Dr. Christy Teal, she co-authored No Longer Radical, Understanding Mastectomy and Choosing the Breast Cancer Care That's Right for You. Dr. Brem?
Thank you so much. And thank you to the Breast Cancer Early Detection Coalition. I feel so fortunate to be here today, and I feel that I am a bridge between the survivors and the physicians, because at the age of 37, at a time that we did not use additional screening in women with dense breasts, and 4 months after a normal mammogram, I found my own breast cancer while trying ultrasound equipment in my practice. But I'm here today to tell you about breast density and about breast cancer in younger women. If I could have the next slide, please. 1 in 8 American women will develop breast cancer. Over a quarter of a million women will develop it in the United States, and way too many women will die of their breast cancer. It's the most common cancer in women and the second most common cause of cancer death. Breast cancer is 30% of cancer deaths in women in the United States. And tragically, there's a 71% increase incidence in cancers in people under 40, with breast, lung, and colon cancer at the top of that list. That's the hard news. The good news is that we've made an impact. And the death rate from breast cancer has gone down by 50% over the past 3 decades. And that's because of early detection and additional care and targeted therapy. And in fact, we know that if breast cancer is detected early, that we can cure, survive, and thrive with it. Next slide, please. So what is dense breast tissue? You've been hearing so much about it. It's really very simple. It's the ratio of fat, or the non-dense tissue, and connective dense breast tissue, fibroglandular tissue in the breast. It's normal. About half of the women in the United States over the age of 40 actually have dense breast tissue. And the only way you can tell if you have a dense breast is by a mammogram. Now, the reason up to 60% of breast cancers are not seen on mammograms in women with dense breast tissue is because of these pictures that you see on the right. The picture most on the right, you see a polar bear with the blue sky. There's contrast. But the picture to the left is a white polar bear with a white snow background. Where does the polar bear start and where does the snow start? And the same challenge is what keeps breast imagers and breast physicians up at night. How do I find a white breast cancer in the background of dense white breast tissue? And it is really the perfect storm, because not only does dense breast tissue make it difficult to find cancers, but it markedly increases your risk of breast cancer. If you have dense breast tissue, you have a 4 to 6-fold increased risk of developing breast cancer. Next slide. Now, how do you tell if a woman has dense breast tissue? You can't tell by physical exam. Currently, the only way we can tell is with the mammogram. On the left, that gray area is not dense tissue. On the right, that white is in fact normal dense tissue. And we grade it by A, B, C, and D in quartiles of whether a woman has dense breast tissue or not. Next slide, please. Now, here you see a non-dense breast on the left and a white cancer. Very easy to see because of the contrast. But the woman on the right has an even larger cancer than the one on the left, but you can't see it, and I can't see it, and physicians can't find it. And you've heard the consequences of that. And that's because the cancer is white and the breast tissue is white. And again, up to 60% of breast cancers cannot be seen by the masking effect of dense breast tissue and the white breast cancer. Next slide, please. So can we find these hidden cancers? And it is critically important that we find these cancers because these are really important cancers. And you might say, well, every cancer is an important cancer, and that's true. But the cancers that are hidden by dense tissue in a mammogram are largely small, node negative, potentially highly treatable, but invasive, potentially killer cancers. And we can find these additional cancers. And you heard that today from Kaitlin and Kristen, that the ultrasound found their cancer that was not seen on a mammogram. Ultrasound is more accurate screening in addition to mammography when women that have dense breast tissue. And in combination with mammography, ultrasound finds 25% more cancers, largely these invasive cancers. And MRI finds even more cancers and is a method that is recommended for screening women with annually that have a markedly increased risk of developing breast cancer, like strong family history, genetic mutations. And not only ultrasound and MRI, but other technologies like molecular breast imaging and contrast-enhanced mammography that you're going to hear more about later can find these hidden cancers. Next slide, please. So if you find early cancer, and then 95% of women survive and thrive, like some of the women you've seen here today. But in women with dense breast tissue, up to 60% of cancers are masked. And we have the technology to find these cancers, like ultrasound, like MRI. But today, we have to force women to make the dreadful decisions, like Kaitlin's mom, whether they'll feed their family or have used their funds to find early curable breast cancer. And it is very important for everyone listening to know that it is not a question, but rather a fact with a profound amount of data that if you have dense breast tissue, you do need additional testing in order to find early curable breast cancer. And no woman should have to decide between feeding their family and obtaining life-saving early breast cancer detection and screening. Next slide, please. And this is either further magnified by the fact that there's been a marked increase in breast cancer in young people since 2012. And the incidence has increased by 1% per year in those over 50, but almost 1.5 times that in women under 50. 20% of breast cancers occur in women under the age of 45. So we're not talking about a rare occurrence. Next slide, please. And there are other populations like Black women, like Ashkenazi Jewish women who have a much higher prevalence of genetic mutation, who are more likely to develop earlier, more aggressive breast cancer and are more likely to be diagnosed with the most aggressive kinds of breast cancer, triple negative breast cancer. And as you heard earlier from Linda, Black women are much more likely to die of their breast cancer than white women, and they deserve better than that. Next slide. Now, we don't know why younger people are getting more cancers, and it's probably very multifactorial. Obesity, alcohol, estrogen exposure, environmental carcinogens, and the changing diets. We know that a healthy lifestyle can decrease your risk of breast cancer, but it does not prevent you from having breast cancer. And therefore, we have to find ways to diagnose the earliest, most curable breast cancer in all women, regardless of their age, their ethnicity, or any other, or their financial situation. And that's why we are all here today. Thank you very much.
Thank you.
That's great.
Okay, thank you, Dr. Brem. We will. I just want to remind folks to post questions in Q&A so we can come back and explore some of these very important issues that you raised. We talk about family history, and yet Kaitlin had the experience she had. So a lot more needs to be done. Next, we'll hear from Dr. Emilia Diego, a leading surgical oncologist who is co-director of the UPMC Hillman Cancer Center and McGee Women's Hospital Breast Cancer Program. Dr. Diego?
Thank you so much for the opportunity. And I have to say, I am so grateful for the powerful stories that everyone shares, because it just magnifies the voice that we are using to be able to advocate for early detection. And I thank the Breast Cancer Early Detection Coalition for the opportunity to be a part of this panel. I'd like the next slide, please. Current breast cancer care is extremely personalized. I talk about this from the perspective of a surgeon and essentially somebody who treats breast cancer. Treatment is tailored and right-sized to the kind of breast cancer that somebody has, whether it is hormone positive, HER2 positive, or triple negative. We call this the cancer phenotype. And this in turn is what allows doctors to determine what kind of treatment to provide a person. Next slide, please. The goals of treatment, if we can find it early, are to eradicate present disease and prevent a future recurrence. This is what promotes breast cancer survival. Treatment usually consists of a combination of local therapy to the breast with surgery and radiation, as well as systemic therapy that can be a combination of hormone therapy, chemotherapy, and more recently, targeted therapies against things like the HER2 receptor or checkpoint inhibitors. Some of these more targeted therapies can be thought of as forms of immunotherapy because they capitalize on the body's own ability to fight foreign invaders and destroy the cancer, which is something that a vaccine can do as well. Next slide. Here is a very complicated, but actually more precise schema that demonstrates that in addition to conventional therapies, such as surgery, radiation, and chemotherapy, there are now so many other options for treatment that are considered novel or emerging, depending upon whether or not a breast cancer is PDL positive, whether somebody has a BRCA gene pathogenic variant, or a hormone receptor mutation. One of the research projects, in fact, that I am involved in is a trial for a breast cancer prevention vaccine that we have available here within our university. But even in a resource-rich country like ours, it's still important to consider, next slide, please, what the cost of that care is. Next slide. This busy slide is a table from a 2019 publication showing the cost of breast cancer care by stage of diagnosis around the world. I don't expect you to read this whole table, but what I'd like to do is highlight the most recent US study that by current standards is likely a gross underestimate because this is in the era of treatment that did not include modern immunotherapy. Next slide, please. This is the study that I'm referring to out of that big table, trial or investigation by Dr. Blount et al. In 2016, which looked at the cost of treating breast cancer in the year 2010, with patients who were followed for only up to 2 years of diagnosis, where an aggregate cost of their health care was looked at. And as you can see, the cost of treating stage 3 or 4 breast cancer, which are the two last columns on the right side, is double that of treating stage 0, 1, or 2 breast cancer. And this is based on US dollars in the year 2015. Again, this does not even take into account novel therapies like immunotherapy or HER2-directed therapy. Again, I want to point out that this is only taking into account the first 2 years of diagnosis and doesn't even include the enhanced surveillance and intense follow-up and testing that these patients continue on for years to come. Next slide, please. In addition to that, as you've heard from these personal stories, what is not typically acknowledged is that in addition to the tangible cost of cancer treatment, patients are significantly affected by a complex web of financial sacrifice in order to cover these costs, including cutbacks on household budgets, challenges with healthcare costs, career advancement or constraints or decisions to change or pivot because of a diagnosis, depletion of assets, and inability to pay bills, as you had recently heard. And in a survey of over 1,600 cancer survivors, those who incurred a debt of $10,000 or more were significantly more likely to report social and economic impacts, including housing concerns and strained relationships. Next slide. In addition to those measurable financial costs, there are a myriad of other under-recognized personal effects on a person and their family when they're affected by a breast cancer diagnosis. Distress in breast cancer, or distress in cancer specifically, has been defined as a multifactorial, unpleasant experience of a psychological, social, spiritual, and/or physical nature that may interfere with one's ability to cope effectively with cancer. It affects up to 40% of breast cancer patients and is more likely to happen in young, non-white patients with less formal education who had a mastectomy instead of a lumpectomy and are receiving hormonal therapy, as well as have a pre-existing mental disorder at the time of cancer diagnosis. Thank you very much.
Thank you, Dr. Diego. Next, we'll hear from Dr. Stamatia Destunis, who is chair of the ACR Commission on Breast Imaging and managing partner of Elizabeth Wend Breast Care. And she's a leader in advancing clinical guidance for breast cancer screening. Dr. Destunis?
Yes, hello. Thank you so much for the opportunity to speak at this venue. Thank you to the organizers and also the prior speakers for their powerful journeys that they shared with us. So we're going to be talking regarding breast cancer screening and the current American College of Radiology recommendations. Next slide, please. We've heard about mammography screening already today, and we know it's not perfect. However, we have had several studies over many years looking at mammography screening, and we know that it leads to reducing death from breast cancer. The randomized control trials are decades old, possibly with quite outdated equipment regarding what we have now, but we found 30% reduction in breast cancer deaths by screening even with those outdated studies. The observational studies are more recent and clinically relevant to a breast radiologist like myself that sees patients every day. And we find overall a 50% reduction in breast cancer deaths by screening. The benefits of doing mammography in most patients is we're finding cancer at an earlier stage, smaller tumors. We've already heard about this, how important that is, that are lymph node negative. They have a better prognosis. And also you have the reduced likelihood then with a stage 0 or stage 1 tumor of less aggressive treatment and less morbidity. We heard the sequela of having, aggressive treatments and how that can be, that can take on your whole life after the treatment. So mammography is the recommended standard for breast cancer screening, for early detection, for the average risk patient, starting at age 40 and then every year. And there's really no upper limit as long as the patient remains in good health and is able to undergo any additional evaluation from a screening mammogram, any needle biopsies that may incur, and also the surgical treatment that may be necessary. Next slide, please. Digital breast tomosynthesis is the better mammogram. It's the most up-to-date mammography screening technology, and it involves us acquiring several low-dose x-rays. It's a series over a range of angles, and the different vendors have different angles that they acquire these x-rays. And these images are reconstructed to provide a like 3D image. So the research has shown that tomosynthesis, the 3D in slang, is better than the 2D, the digital mammogram we had until recently, because it enhances us looking into tissue that's dense, into tissue that's overlapping other breast tissue. So it does reduce callback rates. Those are the false alarms that have patients coming back for those additional views because we have overlapping breast tissue. So it reduces those false alarms, and it also finds more cancers. So it increases our breast cancer detection. And really, tomosynthesis over the years has shown that it can reduce it increases breast cancer detection and reduces callback rates in fatty breast tissue and even the more dense patterns. It is limited, though, more limited in the more dense breast tissue. Next slide, please. Now, screening breast MRI is also something the American College of Radiology is recommending, whether you're using the abbreviated or the full protocol. So MRI is a screening tool. It's very sensitive and also has high specificity. Multiple studies have shown over the years. And really for patients that are considered at higher risk for breast cancer. And who are those patients? They are maybe the patient with a genetic mutation, a strong family history. They may have had chest radiation at a young age, even upper abdominal radiation that may involve the lower part of the breast. They may have a personal history of breast cancer, especially if they're less than 50 of age when they were diagnosed, or they may have a borderline lesion that's considered high risk or an atypical lesion. High breast density on the mammogram is also considered as a risk factor, and a patient may benefit from the abbreviated or full protocol. And then race and ethnicity is also on our list. So MRI in these high-risk women, high sensitivities, close to 100%, and high specificities. Many studies have shown that. It also consistently shows us that by doing MRI, we're, shifting diagnosis to an earlier stage. Of course, then, these patients do so much better. Their prognosis is better, the long-term survival is better, the treatment is less invasive. And it reduces the interval cancers. Those are the killer cancers that occur in patients in between screening cycles. So MRI helps us detect more of those interval cancers, thus reducing mortality rate from breast cancer. Next slide, please. So the latest recommendations from the American College of Radiology, and these have been published for breast cancer screening, that all women should have a risk assessment evaluation by the time they're 25, especially women that are minority women, because we want to ensure, are they in a higher risk category or not, and then really create a screening protocol for them that's appropriate. And then everyone else that may not have the strong family history or other reasons to be considered high risk, start your annual mammogram at 40. Continue screening if you're in relatively good health and can undergo the workup or even a surgery if we do identify something in your breast past age 74. And then the high risk women should have mammography and MRI. Those together show us the highest sensitivity and specificity. Next slide. Now, but how about other studies? How about supplemental ultrasound, let's say? Well, the American College of Radiology realizes that there may be a significant number of women that may qualify, they're higher risk, they qualify for MRI, but they cannot have MRI. They're claustrophobic, they're allergic, they have metal. So supplemental ultrasound also may be helpful for the women that are considered high risk, especially in women with dense breasts. But you have to know that screening ultrasound will find more cancers, small invasive cancers in dense tissue that may be lymph node negative. We want to find those. But it also will increase callback rates. It may increase short-term follow-ups. It may increase false alarms. And it also will increase biopsies, needle biopsies that are benign. So that does happen with ultrasound, although we do use it quite a bit, and it is a good tool to find more cancers. Next slide, please. Other supplemental screening modalities the American College of Radiology is recommending in cases where you cannot have an MRI, contrast-enhanced mammography is another strategic tool here, especially in women with dense breasts. We're going to hear more about contrast enhanced from our next speaker. But if they cannot undergo an MRI, consider another contrast study like contrast enhanced mammography. Molecular breast imaging is also out there. Large prospective studies, the data is being collected currently, and that may turn out to be potentially a benefit for screening of these high-risk patients also. And next slide. Thank you.
Thank you, Dr. DeSunis. Our final speaker before we take questions is Dr. Maxine Jockelson, who is the Medical Director of BreastLink Beverly Hills, RadNet, one of the country's largest networks of imaging providers. Dr. Jockelson?
Thank you so much for having me, and I feel very privileged to be following all of those talks and to tell you a little bit more about newer technologies that we can add to what we have to find breast cancer earlier. And just as an FYI, we actually do 1.8 million mammograms a year in our company. And so among the things that I think are new and very exciting in the setting of finding breast cancers earlier and more affordable include AI and contrast mammo. So to begin with AI, artificial intelligence is something we talk about in all walks of life every day. And it is something that people think can be used for bad reasons and for good reasons. But for breast imaging, artificial intelligence can be very helpful. So artificial intelligence can be done on anything that has a digital background. And the nice thing is that each pixel in these digital images provides information that we cannot see with the human eye. But AI can recognize the complex patterns in the breast tissue, which can transform the image interpretation from a purely qualitative and subjective task to one that is quantifiable and reproducible. And while everybody says, oh my God, AI is going to replace human beings, it's not, but it can certainly help us, particularly when we're looking at mammograms. So first of all, in terms of improving our diagnostic capabilities, AI can detect cancers that we cannot see. And so as we're reading these mammograms, if you have AI as well, it can let you know that there is something there that you either have missed, because we certainly can miss things that you can see, or things that you cannot see, but it's giving you a message that there is an abnormality there that you cannot see, and tells you you need to go look at something further and use some supplemental imaging. In addition, it can integrate the images with genomic information, if that's in the patient's chart, pathology, and electronic health records to make a better diagnosis. So now it's putting the whole patient together, and you can see that that information is very helpful. Additionally, contrast AI can be used in assessing risk of cancer by looking at the breast tissue itself, different from some of the ways we evaluate risk, and it can help put people in high-risk categories. As a way of improving access in populations of patients where there are not enough mammographies around, it can also help you sorry, it just advanced my slide. It can also help you decide which patients are less likely to have cancer. And in cases when there are not enough breast imagers, it can be a second reader or even a first reader in women who are not at high risk. So moving on to contrast enhanced mammography, and this is an advanced application of a digital mammogram. And this is something that can be more affordable. It's going to be half the price of MRI at least, and more accessible in communities where there are no MRIs available. It can even be put on a mobile van. So this technology uses the injection of contrast in a way that MRI does to find the leaking neoplastic vessels, and the leak will go into the breast tissue and you can image it and find a cancer before there's a discrete mass, just like we do with MRI. It is particularly useful in dense breasts, and we've already talked about how we miss cancers otherwise. It can improve our accuracy, efficiency, and it's less expensive and more accessible. Next slide, please. So I think sometimes a picture is worth 1,000 words. This is a patient who presented to us having had a breast mass for 3 years. She came to see one of our surgeons. She had had yearly mammograms, yearly ultrasounds, and a biopsy, all negative. So the surgeon called down. She said, what should we do? I said, let's just give her some contrast. And on my right, your left, you can see in that right breast in a huge amount of contrast enhancement in an irregular pattern. I ultrasounded it. Ultrasound was still negative. We did an MRI biopsy, and this is multicentric invasive lobular cancer that could not be seen on routine mammography or ultrasound. Unfortunately for this woman, it was too late. She had metastatic disease and died of the disease, but it shows you that even if you can't afford MR or you can't find an MR, this contrast mammography technology is another very powerful way to take care and find early breast cancers, especially in women with dense breasts, and especially in people who are underserved and can't afford some of the more expensive technology. Next slide, please. And so coverage for these supplemental imaging exams, such as contrast mammography, ultrasound, and MRI, can vary depending on the state. Advances in technology and such as contrast mammo and AI will continue to enable earlier breast cancer detection, resulting in less need for treatment. Without insurance coverage, however, many patients may be unable to afford critical supplemental imaging, which will result in late-stage cancer diagnoses and lives lost. And that is why the Find It Early Act is critical.
Thank you, Dr. Jacobson. All of our speakers have shared powerful insights, and with the few minutes that we have left, I want to direct a few questions that we've gotten in. Please keep putting your questions in, because obviously this is going to be recorded, and the questions and responses will be part of the recording that you can find that'll be shared with everyone who registered. A couple burning questions came in. Dr. Stunis, one is to sort of clarify the differences in the various technologies. Is one better than the other? And how can we tell which type of screening to ask for? What is it that we as patients need to know in terms of making sure that we get the best screening for us?
So I think for the patient that is considered of average risk, when they're of the age to start screening, you would ask for a mammogram to start out with, because although it may not be perfect in every situation, and we've heard these stories of where dense breast tissue, it wasn't seen, I would start with that, because we need to first identify what our breast density is. So the mammogram will tell us that. And then that will set off also what other supplemental screening do we need. If dense breasts and no other history, if you're not a minority, if you're not considered high risk because of, genetic mutation or anything like that, you can consider supplemental screening with ultrasound, which Dr. Brem so eloquently explained does find invasive cancers that are lymph node negative, and we can start there. But if you are at a high risk, if you are a minority, if you have any concern, I think the important thing here is to sit down with your doctor and go over your family tree and have a very nice risk assessment evaluation to find out where you fall early on, and then make a decision about strategic supplemental screening. Certainly, MRIs are most sensitive, most specific tests, and then contrast enhanced mammography and molecular breast imaging. I think anything with contrast is going to give you more than anatomic information. It's also going to give you functional information and activity in the breast, which is important, especially for the women with dense breasts. And so those could be very appropriate in the right setting. But I do think that risk assessment evaluation has to happen to find out where you fall, and then what do you need, and we need to know what your breast density is. So the mammogram is a good start to get the lay of the land, and then move forward with additional supplemental screening.
Linda, I'd like to add to that the people on this program should understand that a 3D mammography is not supplemental screening. If someone tells you that you have dense breast tissue and you've had additional screening because you've had a 3D mammogram, that is not correct. You need additional screening if you have dense breast tissue. It's not a question, it's an absolute. Whether you need ultrasound, MRI, excellent to discuss that with your physician.
Right.
And the other thing you need to know is that in this situation, no does not mean no. Generally, no means no, but it does not mean that here. If your insurance company says no, you call them back. You have another physician advocate for you. You need to raise your voice, You do not assume that everything is going to be done right for you, because you need to know that nobody knows you as well as you know you. And you do have to raise your voice to advocate for yourself to make sure that you get the kind of
Exactly.
care that Kaitlin's mother deserved.
That's right. So digital mammography and tomosynthesis are two different types of mammography. Tomosynthesis is the better mammogram, but it's not supplemental screening, although patients may think that. And you have usually more than one doctor. And we've seen some in the chat say, my doctor refused the MRI. My doctor refused supplemental screening. And I've had doctors call me and say, how dare you do this MRI on this patient? I was like, she has another doctor that recommended it. So we have, there's opportunities here for us to advocate for ourselves.
And of course, all of this then sort of assumes someone has some way of paying for this supplemental screening if it's not recommended, if it's not covered, if you're trying to advocate for yourself. To that point, Dr. Jacobson, a lot has been talked about AI-assisted mammography, AI-assisted ultrasound. There are a couple of questions about the accuracy and how that can be trusted, or how do we view the accuracy of AI-assisted technologies over some of these other technologies that we've been hearing about?
Right. And that's a really great question. So there have been quite a few studies published looking at AI and comparing AI alone, AI to be read with a radiologist to see how effective it can be. And certainly every study has demonstrated that it adds something to the person who is reading the exam. There is definitely additional information that can be obtained, additional cancers that can be found. And so it does add value without being a very expensive additional value to each patient. In addition, AI can now, in certain settings, has been shown to be pretty useful as a sole reader in a setting. Not ideal, but there is a paucity of breast imagers out there. There are people who don't live in communities where there are specialists. And so it's something that certain AIs can tell you the risk of there being a cancer with a very accurate way of doing it. We have one that will tell you if it's minimal risk, it's 1 in 4,500 chances that you have a cancer. If that's what you're doing, the AI can be a pretty good method for evaluating the breast. And so that's one thing that you can do with it. It also, now there are more and more data that say the AI can look at your breast tissue and determine your risk. And in some studies, they can do it more accurately than the risk models that we classically use. So above and beyond family history, breast density, AI can add information with, if you don't have a family history and your breasts don't look too dense, but it can actually independently show that you're at risk, even though you don't have those risk factors that we classically use. And we all have seen patients who say, I don't understand how I could have breast cancer at 25. No family history, none of this. And so this is the kind of additional information that improves your cancer detection rates. In one study we have, it was a 21% improvement in cancer detection with a 7% increase in callbacks, but that's a really good ratio if you're going to find 21% additional cancers.
Okay. And sort of to that point, women are told all the time, examine your breast, know your breast, feel your breast, do it. I think the ACR says self-breast exam is not the way to go. But Dr. Yago, what do you say to women who are examining breasts? And given, Kaitlin's experience, she had a family history. So one would think that her care team would have said, oh, well, you have a family history. We need to do these other things, especially given your experience.
Thank you for that question. You're absolutely right. I think that the idea of breast self-exams that have really fallen by the wayside have really been taken over by a different term that we want to call breast self-awareness. It's a little different in the sense that it doesn't necessarily box you into this idea that you have to be doing breast exams on exactly the same day of exactly the same time every single month, which is more a misnomer, because then you find yourself in this situation where if you feel like you didn't do it the right way, you find yourself maybe potentially blaming yourself for not having found it, right? Breast self-awareness, however, comes with this notion that you're aware of your body, which I think everyone on this call has been advocating mostly for, and really talking to your doctor about what your potential concerns are and risk factors, because that is what will help us as physicians, even if we can't see something, order the appropriate diagnostic imaging to help find that.
Okay. And I think we've got time for one last question, and this is about coding. The question is, if you have a mammogram and there's something and it turns out to be nothing, you actually get then pushed into the diagnostic category the next time, so that affects your copay, it affects some other issues. What is sort of the guidance for supplemental screening if that happens versus, getting coded as diagnostic? What is it that we patients can do and can ask for? And, how can we avoid, high cost and unexpected expenses?
So Linda, if you get called back because we see something, so supplemental screening doesn't have a role then because you are a diagnostic. We're working through something. So you may start with additional mammographic views, tomosynthesis views, the 3D mammogram, the tomo. It may end up with an ultrasound and even a biopsy if we do see something. So all of that, this is why this call is so important, because this is what we want to be covered. We want to find it early. All this movement that we have is so for women to be aware that it's not just a screening, it's everything that comes after. And we want those tests to be able to be covered for the patient so they don't have any out-of-pocket costs. I think if you just have dense breast, you can ask for supplemental screening, whether you're high risk for MRI or another contrast study or ultrasound. But if you get called back, then you're a diagnostic and we're working through an area in your breast.
But it's important for everyone to know that screening mammograms have no copay and no deductible, according to the Affordable Care Act. And the reason we're here today is even if you're covered by insurance for supplemental screening, ultrasound, MRI, molecular breast imaging, that there is a copay and a deductible, and that could be prohibitively expensive to implement these very effective tests for women. So we need to really extend policy so that women do not have to make the decision, even if they're covered by insurance, to have to pay copay and deductibles, which can be quite high, in order to get whether it's supplemental screening or diagnostic tests.
Exactly. So the mammogram may be covered, but everything else goes to the high deductible plan. And then that can be quite expensive for them.
Only screening mammograms are covered. Diagnostic mammograms are covered by insurance, but not without a copay and a deductible.
And although AI is very attractive and we're all like thrilled about it, there's really no coding for that either. So women frequently have to incur the cost of that if they do want some type of AI. So there's a lot to change.
Well, not all certain. We actually do it without charging patients. So
and we do as well. We use AI at 100% of our mammograms.
That's right, but not every facility does the same thing. And I've had many patients call our office and say, "You don't charge for this, but the business down the street does." So patients have to become their own advocates and ask questions.
So much for patients to be aware of and then know to ask about and ask for. Thank you all so much for your insights and your expertise today. I know this conversation could go on. There's many more questions. They will be answered in the recording, so please come back, look at the recording. The questions will be answered. Thank you for attending this briefing. Just last week, Senators Klobuchar and Marshall reintroduced the Find It Early Act that our speakers, our physicians and patient advocates have talked about. It's so important. And Representatives DeLauro and Fitzpatrick will soon introduce it in the House. So we urge you to speak to your bosses about co-sponsoring this legislation. It is vital to saving lives. And as you've heard over and over again, if we find it early, we can cure it. We don't have to have the kinds of experiences that we've heard about. The Find It Early Act will ensure all women with dense breasts have insurance coverage for the full range of screening tools they need to catch their cancers early and survive. And remember, if we find breast cancer early, it can be cured. thank you so much for attending this briefing, and please refer back to the recording and share it with your colleagues in the field. Thank you so much.